for Greater Manchester. I'm really sorry about the issues you're just having joining us. It looks like we've had some Teams issues in the background, and there's been a changeover. So please excuse the IT. It's not us. Well, hopefully it's not us. And let's hope that the afternoon goes plain sailing from here on. I'm hoping that all our presenters have joined the call as well. So I'm delighted that so many colleagues could join today, and thank you for your time, which we appreciate is extremely busy at the moment. I'm sure you'll agree the agenda has an array of interesting topics from both a clinical and professional development aspect, each brought to you today by colleagues from within and beyond Greater Manchester. I'd like to remind you the session is recorded and request you keep your cameras and microphones turned off throughout the speakers' presentations, please. The chat function will be live and hopefully working, and questions will be answered. However, we had put 2 10-minute spaces within the agenda to open the floor to questions. It may be that we run over or make them quite shorter now due to time constraints. Obviously, in those sessions, if you wish to ask a question to the panel, raise your hand and open your camera and mic when asked. So let's get on. So first, I'd like to introduce you to Helen Pratt. Helen, oh, sorry, are we doing? Oops. Is Helen there, please?
She's got her own slides to share, Helen.
Is Helen on the call?
I don't think she is yet. It might be worth Sam and Dawn doing theirs first.
Yeah. Okay, so I'm going to move on then to, yeah, please, yeah. So we're going to do healthcare support worker training. Okay, so Sam Howard. Sam, are you on the call?
Hi, Leslie. Yeah, here.
Thanks, Sam. Take it away. Sorry.
Thanks, Leslie. So we've for the previous few months, it feels like almost a year now, but COVID has made keeping track of time quite difficult to do. Between ourselves from the training hub and the Greater Manchester Health and Social Care Partnership, working with Hayward, Middleton and Rochdale, I've delivered some healthcare support worker specific training on various levels. So the areas that I've covered is we were looking at the clinical skills that healthcare assistants could perform that's specific to general practice. So if you could move on to the next slide, please. So our content, what we were looking around, was a kind of standardisation of certain things that we knew that there was a great appetite for within primary care. And the reason that we chose to work with our healthcare support workers was specifically to do with the CPD funding that we've had nationally for our registered healthcare professionals, which unfortunately healthcare assistants don't fall into this remit. So we recognised a gap. The training hub was administrative from HEE around the workforce development funding 2 years ago now. And the common themes that we pulled out from that were around access to spirometry, venipuncture and immunisation. So that was why we chose these specifically to work on, because we knew that the appetite was there. But what we also recognised was that there was a massive gap in equity to this access to this, and also a huge variance in cost to the NHS. So what we wanted to look at was a completely GP specific access to clinical skills that our healthcare support workers could have a fair, equitable access to. Next slide, please. So to date, we've had 42 delegates who have undergone venipuncture training. That's been socially distanced, face-to-face training. So it's been a little bit of a task because we've had to use really small numbers to get that out there. The feedback's been really good from that. That went down really well. The spirometry access, which is preparation to a portfolio for spirometry, so it's not interpretation, it isn't the doing of spirometry, it's around getting the foundation right for almost the legalities about that and preparing yourself as what to expect to build up to actually the performing and then the interpretation would be for our registered colleagues, not for our healthcare support workers. And we had 54 people attend that remote session too. Next slide, please. And just a little bit of the feedback that we had. There's been lots and lots of feedback, but I just wanted to put a little bit onto a slide. And one of the interesting things that I hadn't occurred to me up until this point of delivering this training, that we actually invited some patients to come along. So some of the advice that we give to our clinicians, so that we could have a patient's perspective and they could also understand what we're taught and why we're taught. And it was actually really quite beneficial to have them there, so that we could really make sure that we kept that patient focus to all this. So that's a real whistle-stop tour to that. So I'll keep it really short because I'm conscious of time too. Next slide, please. Any questions?
Thanks, Sam. We have a question and answer session built into the agenda. If you can stay with us till 1:30, will that be okay?
Yeah, no problem.
That's great. Thank you. Should we move on to Dawn?
Hi. Okay,
Thanks,
so I'm Dawn O'Brien and I am the HMR Primary Care Academy Manager. So just following on from Sam, we've all been working together to look at how we can upskill our healthcare assistants within primary care. And a lot of the practices now are looking to reshape their workforce by upskilling their healthcare assistants to alleviate the pressures on our stretched nursing teams. We have been working with Greater Manchester Health and Social Care, Moira, Salford Primary Care together, and the GM Training Hub, plus a lot of our other workforce leads and nurses from across GM to look at how we can expand the HCA workforce within primary care. We've got quite a few offers out at the moment, and there is going to be an updated offer going out this week with a flyer. There is an expression of interest form that needs to be completed, and what we do ask is when that's filled in, is you can put in the current role, previous experience and qualifications. And there is also a box that says that you're looking to upskill your HCA or receptionist to go on to do either the trainee nurse associate or the registered nurse degree apprenticeship or the level 3 apprenticeship. The foundation programme that we've all developed is providing a quality developmental route for existing staff or new recruits, and it's a cost-effective solution to recruitment and employment. We're working in association with Berry College to provide ongoing support to practices involved in the foundation programme, and we've just been very lucky to receive further support from Hotwood College around some level 2 training. Next slide, please, Claire. So the current training that we offer, sorry, I'm struggling to see my own slides on Teams. Next slide, please, Claire, or Karen. Oh, thank you. So the current training that we've got is the level 3 diploma in healthcare support. We're offering the care certificate. We do offer the level 2 English and maths if people have not already achieved this, and we do require proof if your HCAs or receptionists are saying they've got GCSE or something else, and we do require proof of those. We're offering phlebotomy training, and we've got the e-learning programme, which concentrates on core clinical skills, health screen awareness, chronic disease, hypertension, blood pressure and urine dipstick analysis. These modules are delivered via a blended mix of online self-directed study and live taught webinar sessions, and we've had great feedback from these sessions so far. Next slide, please. So we've been discussing with Hotwood College in the last few weeks, and they've offered to do additional training, and we can use the adult education budget to be able to provide some additional bolt-on modules. They include health and safety, infection control, mental health awareness, and mental health first aid, which I don't know if you're aware, but mental health first aid is quite costly. Difficult conversations, professionalism, person-centred, compassionate care, health promotion, and working with our mentor would offer the care certificate. Next slide, please, Claire. So far, we've completed phlebotomy training, the learning training, functional skills, and we've been completing one-to-ones with some of those that are rolled on the course. So we've got, so far, I think we've got 58 on the course, and we've got spaces for around another 80 to join. We've been completing one-to-ones with these, and out of the ones that we've done, the majority are really interested in the nurse associate role. We've got a few who are interested in the level 3, and a couple who have got the qualifications already to go straight into the registered nurse degree apprenticeship. In order to sort of give people the opportunities and the background around where they go next, we've been doing information sessions. So Deborah Holden, who's up next, has kindly been doing some sessions with practice managers and the HCAs and the receptionists to say this is what the nurse associate course entails and what the funding is available. We held an absolutely phenomenal HCA forum. The feedback from that was just brilliant. HCAs across GM said that they have never had a forum that's been able to give them this information and to look at upskilling them in a way that we're now able to offer. We've employed a brilliant mentor, and she's called Elaine, and she starts with us next Tuesday, and hopefully she will be at the next forum. Next slide, please, Claire. Our next steps, we've got a lot more one-to-one sessions to go through, and we're also working with Sam at the training hub to look at the staff that she's been training with the phlebotomy and the spirometry, so we can look at developing those and offering them one-to-one sessions to access the nurse associate course, the level 3 or the registered nurse degree apprenticeship. We'll hold more information events, again with Deborah Holden and with Bolton University. Our mentor, Elaine, is going to hold regular monthly forums across Greater Manchester for all HCAs and receptionists who are doing phlebotomy and other things. And the offer is going to go back out across Greater Manchester. We just knew it doing some more slides with some more information and a new flyer to go out to everybody. And I just wanted to say, feedback again has been phenomenal, and thank you to everybody who's given their input into what is needed for our healthcare assistants. Next slide, please, Claire. So some of the questions we have had is, we already have a HCA. Why do we need more, and why are we upskilling them? We do know that there will be 33% less nurses over the next few years, and our HCAs can relieve some pressure on already stretched nursing teams, especially with the introduction of the nurse associate role and the nurse apprenticeship. HCAs are potentially our future nursing workforce. There is no cost to the practice, and you're able to claim backfill. And we're here as a team to support you to make sure that whether it's your healthcare assistant, receptionist or phlebotomist or another member of staff, that we're able to guide them and to look at how the levy transfer works with the universities and the colleges, so that there is no cost to the practices. And that's me done. Thank you, everyone.
Thanks for that, Dawn. That's superb. And Dawn's going to stay around for questions. I know there's quite a few in the chat there, so hopefully we can open some of those up, Dawn, later. Thanks for that, Dawn.
Thank you.
I'm going to lead on now quickly to Deborah Holden. Apologies for that. Deborah's a nurse and a lead practice education facilitator and operational lead for trainee nurse associate programme in Greater Manchester. Thank you, Deborah.
Thanks, Leslie. Okay, now before I was asked to present this, I contacted Health Education England and asked them, could I actually use one of their slides presentations that they viewed before, because we want to make sure that there's a clear message across GM about what we're offering with the training nurse and associate programme and what that role entails, because there are quite a few myths about the trainee nurse and associate role. So even though I'm going to go quite quickly through this presentation, it's a little bit of myth busting, questions and reservations and misgivings that some of our nursing workforce have about the nurse and associate programme. So here we go. And if you've got any questions, please pop them in the chat. I won't be able to remain later to answer them, but they can be forwarded and I'd be happy to address them personally to you in an email. So this is about the trainee nurse and associate. Next slide, please. So the nurse and associate role was brought about after the shape of caring review in 2015 and the recommendations that were made from that. And it saw that there was a gap. There was a gap in having skilled people with the right behaviours, attitude and training to look after our patients and people within our care that didn't necessarily have to be undertaken by a nurse. So the legacy cohort was commissioned in 2019. Now, at that point, they didn't have the support of the Nursing and Midwifery Council. This was commissioned by Health Education England, and it was only in the second year of this programme being run that actually the NMC said, yes, we will be their awarding body and they can actually come onto our register and have a pin. So the legacy cohort, the first ones registered in 2019, and they registered in a variety of settings. So they were in the community, they were in primary care, and they were in the acute hospitals. Next slide, please. So the nurse and associate rule, the first thing I'm going to say is nursing associates are not nurses. They are part of the support workforce and are registered with the NMC. They have their own PIN, like I've mentioned, and they have their own set of proficiencies. So they are not nurses. So the first myth, they're not nurses, they're part of the support workforce. Hence, they can't replace nurses. There's a synergy. They work alongside them. It's an additional role within our workforce that we needed. So nursing associates can work independently, but they must always work under the umbrella of nurses or of a registrant. So we can never, ever diminish our nursing workforce. That must continue to grow. And as long as we've got nurses, we can have nurses associate. They work together. Without one, we can't have the other. They are supervised, they are assessed by you to ensure they're competent to become part of your workforce. Next slide, please. Okay, so like I previously mentioned, it was brought about to bridge that gap between releasing the nurses to do the more complex cases so that this support workforce with the skills and the knowledge and the right behaviours could look after the less complex cases so that there was care continued. Okay. They are generically trained, so whether they work in the hospitals, whether they work in primary care, whether they work in social care settings or in the community, they still get the same generic training. So that means they still have to have exposure, the same as nurses, to people at home, close to home, and in hospitals. They still need to have the exposure of the 4 fields of nursing. So that means they must cover adults, they must cover mental health, learning disabilities and children and young people. So they have that same exposure. And that is an NMC requirement, because on this programme, there's 2 things. Within primary care, we predominantly focus on apprentices because we want to develop our workforce. We want to give them a pathway to develop. So they're not nurses. So what we want to do is we want to open opportunities to people to develop on a pathway where we keep our staff and they can go up and become skilled and possibly go on to be registered nurses. This would be a pathway that would not have been open in the past if we'd stuck with the traditional way of training people to become nurses. So that's why it's so interesting, and people, HCAs, want to engage with it and employers want to engage with it. So just to give you an idea of our attrition rates, at the moment we recruited to the first cohort 25 TNAs, trainee nurse and associates. We currently still have 25 on programme. I have never worked on a programme where we don't have any attrition, and that just shows you the level of commitment that these individuals have to wanting to be part of this workforce and developed. They're actually doing a foundation degree. Now that foundation degree is a level 5 in nursing associate. Now again, they're not comparable with nursing. Nurses, once registered, have to be a level 6. So the knowledge of a nurse and associate is capped. So if they want to go on and if they want the additional roles that nurses do, they then have to go on and do a registered nurse programme. They step on to year 2 of a registered nurse programme to get that additional skills and knowledge. So I hope you're now starting to see the differences between the two roles. So it is a registered role, and like I've said, there is progression onto nursing. Next slide, please. So here are some of the things that show you the differences between them. Yes, they will be accountable professional like all registrants. You're accountable to your awarding body. Yes, they will promote health and prevent ill health, but what don't they do? What they don't do is they don't evaluate care, they monitor care. It's up to the registered nurse to evaluate care. A nurse and associate can work within a team. They cannot lead and manage a nursing team. So traditionally, if you had three registrants, you'd have 2 of them would be registered nurses, and your 3rd one would be your nursing associate, still a registrant, but can you see that that nursing associate could never manage or lead those registered nurses? They can manage and lead their own workforce, nursing associates, and they can manage and lead the non-registered workforce, but they could not manage and lead the nursing workforce. And here we go, another difference. They can contribute to integrated care. They cannot coordinate it. And finally, there isn't even a platform for this because they cannot do this. They cannot assess needs and they cannot plan care. So those are significant differences. So when you're looking at your workforce, you need to look at your skill mix. So what we couldn't have within primary care in a general practice would be too many nurse and associates where they could not be overseen by just one nurse. Because of the level of care, the acuity of patients within primary care, you would need to make sure, as within an environment, that you had the right skill mix. So don't feel, for want of a better word, threatened that all of a sudden they won't be recruiting nurses, they'll be recruiting nurse and associates. You are meant to work alongside one another to support one another. They would take away the less complex cases and the routine tasks where you would need expert knowledge and clinical skills, so they could continue that care, but they would not take over your role. They would continually be coming back and feed it into you to make sure you were happy with that care. So we need to make sure the skill mix is correct. So if we look at a social care setting where the acuity of patients is very low, possibly in a nursing home or a rehabilitation centre, yes, you may have several nurse and associates overseen by possibly 1 or 2 registered nurses, because that's appropriate. But within primary care, you really would have to look at your skill mix. Next slide, please. Okay, so what is the programme? It's a 2-year programme. We have numerous universities that we do work with. The main ones that we choose to work with are those that will support a primary care element to this programme. So even though it's a generic programme, what we say is we must be able to adapt those skills and take into account what primary care needs. So we tailor the programme to fit primary care. So we work with the universities that will support us in doing that. It's a level 5 programme. In order to come on the programme, the minimum entry criteria is maths and English. And that's why the courses that they're doing across GM now, that Dawn's doing and Sam's doing, are fantastic for this career pathway, because they're prepping people to develop our support workforce to get more and more skilled, and just it's a natural step and progression for them to come on this programme. It's not out of reach anymore. So that's fantastic that we're working together in that way. Now, one of the differences here between nurses and nursing associates is, as you may know or not know, nursing associates do 2,300 clinical hands-on practical hours over the 2 years. Nurses do, I think, if I'm not mistaken, 4,200. So there's a huge gap there, isn't there? So you can't think that somebody who's done a 2-year programme and the requirements are different is a nurse and can step into the nurse's shoes. What they can do is support. The NMC requires them to have a split of 50% of learning time, so that's theory, and 50% time in practice. Now, I'm not going to go into the detail of breaking that down for you, but just to give you an idea of they do spend 1 day a week in university and the remaining time is clinical. That is the balance. Next slide, please. Just like nurses, as I've explained, they have to work in the different settings and they have to cover the different fields. And as I previously mentioned, they must have supervision and they must have assessment. And that supervision and assessment is done by the registered nurses. To supervise a trainee nurse and associate, you must be a registrant, but not necessarily in the same field. But to assess them, you must be in the adult nursing field, or if they're working in a different field, such as learning disabilities, you would have to be in from that field of nursing learning disabilities. So we do need you nurses to support this new stream of workforce in order for it to be successful within primary care. Next slide, please. Funding. Next slide, please. Now, there are a couple of different funding streams for this. So with as it currently went, because I don't want to confuse anybody, because the funding is agreed on a yearly basis. So the last offer that went out for the intake that has now enrolled in March, and they've actually started the learning this week. Health Education England supported them by £8,000 over the 2 years. Okay, and that is to support the practice. It's paid directly to the practice and it's to support them to support the trainee. And it's with travel expenses, uniform, IT, with giving your staff some time to do the documentation, allowing the trainee to shadow that person. There is currently for the programme, this programme, and they are all different from the ones that Dawn and Sam were talking about. We're all different from the HCA programmes to the RNDA programmes to the TNA programme, Training Nurse and Associate programme. There is currently no backfill for this programme. That is what you get, the 8,000. That has to be agreed now for the September intake. That is for the adult programme. If somebody goes on to a specific learning disabilities programme, then there is more funding for that. Fingers crossed it's still in place for the September intake. Next slide, please. Yeah, next slide, please. That's about the learning disabilities enhancement. So the practice doesn't have anything to pay towards the actual training that we get gifted by the apprenticeship levy. So we support you in all that activity. It's £15,000 over the 2 years for the entire training, and the practice is not liable to pay any of that at all. But Health Education England does have an expectation. If they're going to support the training and development of a workforce within primary care, we have to have a low attrition. We need to keep that workforce within primary care. And like I've already said to you, from the 25 that started the programme, we've got 25 still on programme, and they are very, very committed to primary care, and they've got no intentions of going anywhere else. And what I'm going to say here at this point as well is, this has been raised. As you know, primary care are non-NHS employers. That means that they do not fall under Agenda for Change. So they are not paid a band 3 whilst they're training. They are paid whatever rate the employer pays currently at their practice, if they are paid directly by the apprentice, and they're not going via any other scheme such as the additional roles reimbursement scheme. So they're not under Agenda for Change. There are some discussions between them at universities when they all get together what the pay is, but they're not under Agenda for Change, as you know, within primary care. Next slide, please. Next slide, please. So these are the universities that do offer the programme. your practice is under no obligation to come to us for their training. You can go directly to any university, but what we want to do across GM is that tailoring, is that primary care specific, because we know what our workforce needs. We know the skills that they need to have. And as I've mentioned, they have their own set of proficiencies. Now, I will put it on the chat for you, the proficiencies for nurse and associates. Like nurses have their own proficiencies, nurse and associates do. Now, if you go to Annex B, this is the main question I'm asked. Go to Annex B and it will tell you what they can do. It will tell you their skill set. It'll tell you what they have to do, what they have to achieve throughout their training under those 6 platforms that I mentioned. It lists hundreds of objectives, tasks that they have to achieve, and competencies, proficiencies before they can register. And that will give you an idea of actually how they support your workforce and what they can do. So simple things, they can't work from a PGD, they can't give IVs. There are very simple things they can't do. So once you know what they can't do, you understand what they can do. But if you are interested, look at the proficiencies and go to Annex B. This is an incredible opportunity to open a gateway to frustrated people who have more to offer our workforce. You can engage with either Sam or Dawn and they will forward anybody's details to me and I'll answer any questions that you may have. Thank you for taking the time to listen today.
Thanks, Deborah, for that absolutely passionate presentation there. We can see your passion in what you've said there. There are so many questions in the chat here, and we've got time to jiggle the agenda around a bit today. Would you just mind staying just for 5 minutes just to answer some of these questions?
Yeah.
Is that okay? Moira's gone through the chat and she'll ask the people to speak up. Thanks for that.
Thanks, Deborah. That was fantastic. Really, really fantastic slides. So Louise Wainwright, have you a question about, in practice, how does an NA mentoring care different from our current HCA with these competencies?
Hi there. Right, first of all, within nursing and midwifery, if you're under the NMC and you're an NMC registrant, for student supervision and assessment, we don't use mentoring anymore. We use supervision and assessment. So because nurse and associates fall under the NMC, even though they're part of the support workforce, they are supported by our own workforce, by nurses to develop them. So you supervise them, so you have that role model that works alongside them throughout their training, giving feedback to that assessor. That assessor steps in and gives that independent assessment of whether that person should progress or not, whether they need a little bit more time in order to achieve their objectives. And that's how we work now as a profession. We don't mentor anymore. Now, mentoring may be used with the non-registered workforce because that's what they need, but within the NMC requirements, we must supervise and assess. And it doesn't take a lot of time. Once you're used to doing it, we have what's called a transitional phase when anybody steps onto a new program and everything shifts and responsibilities. So it does take a little bit of time, but that's why there's such a support mechanism in place, as in the PEFs, the clinical educators, the wombats, they're all there to come into your practice and support and guide you.
Louise, does that answer your question? It's on mute, I think. So Henrietta's had to leave, but she said, could these be overseen by a doctor?
Right, so in order to a supervisor has to be a registrant, but not off the same part of the register. Okay, so a trainee nurse and associate will register on the adult part of the register. So nursing adults. So that's why the assessor needs to be from that field. But for me, when you're developing somebody within a team, I think everybody's got a contribution to make, whether they're a registrant or not. Officially, the supervisor must be a registrant, but you may have somebody who is very new to this role, and they may need to work with healthcare support workers who are very experienced. They may go to work with assistant practitioners who are incredible within their own right and specialists within their field, and they'll benefit from them. But what they would do is they would then feed into that GP supervisor, who would then feed into the assessor, so the assessor could do a holistic evaluation of that trainee's development. So yeah, of course it can be a GP registrant.
Thanks. Next question from Anne Wilson-Berg. What is the ratio required for RNs to NAs?
Right, it's not about the ratio. Think about your patients, the acuity of your patients. If we were in a nursing home, okay, and there were 8 patients, okay, for want of a better word. I know I'm using a nursing home, but it's just easier with the numbers. So I do apologise for that, but I think it'll make sense. So imagine you've got a bay and you've got 8 patients and they just need continuous care, okay? They're not at the level when they could be in a residential home. They do need nursing care. They need constant medication. What you could have is you could have a nurse and associate in that bay. There'd be no reason to have a nurse in that bay. So that would be 1 to 8. So you'd have one registered nurse to 1 nurse and associate who could have 8 patients, but maybe you've got 3 bays. So maybe you have 3 nurse and associates on duty that day and just 1 nurse. And though that'd be 1 to 3. But maybe you're in practice and you have 400 patients on your list. I would not want to see 3 nurse and associates and 1 nurse. You'd look at the acuity of the patients, you'd look at the clinics that you were running, and you'd think, what clinics would it be suitable and appropriate within their scope of practice for the nurse and associates to do? What close to home, when they were going out doing at-home visits, what would be appropriate for them to go and do, and just feed back into me. So that might just be a 1-to-1. You know, you might have 1 nurse and associate, you might have 1 nurse, and you might have 1 support worker, healthcare support worker. Look at the acuity of patients. So we're not so rigid, we're quite flexible and fluid, but we take into account what you as a professional would consider to be appropriate. Look at your skill mix. Don't just think, oh, what should the ratio be? Because it'd be inappropriate to use the same ratio in all environments. Look at the acuity of patients, look what's appropriate for your workforce. I hope that answers that question.
That was brilliant. Yes, thank you, Deborah. I learned a lot there as well. So we've just got a couple of staff that are currently on the TNA programme saying how passionate you are and they're loving the course, and someone that's working as a mentor to the TNAs on the first cohort. It's an amazing programme and very much worth getting involved in it. So lots of praise for you, Deborah, but thank you so much.
Thank you for your time today.
Thanks, Deborah. Perhaps you can come back again sometime with some of your students. That'd be lovely. Thank you for that.
Thank you.
So we've made some time up now, and unfortunately, Helen Pratt, who was going to give us an update from Dementia United, can't get onto the call today. So we'll ask Helen to come back to our next meeting. We can skip through the Q&As. Thank you, Karen, because we've done that bit. And we'll go to Carol LeBlanc. Carol, have you joined us?
Hi, yeah, I'm here.
Thanks, Carol. Carol's a nurse and is the head of Greater Manchester Project Management Office. And Carol's got details of a very exciting opportunity for advanced practitioners in Greater Manchester. Thank you, Carol.
Okay, I'll just share my slides. I've only got a few, so I'm not bore you to death. Can you see those?
Yes, thanks.
Okay. Right. Okay, so my name's Carol LeBlanc. I'm head of the Greater Manchester Programme Management Office, which is outward facing into the system, looking at nursing, midwifery and AHP, workforce supply, retention and development. Nurse by background, worked at Bolton for quite a number of years, at Bolton Foundation Trust for a number of years. So just an introduction. At the beginning of this year, Leslie and I joined together to put a submission in to the HE Workforce Development monies to develop a proof of concept around advanced clinical practice support across GM. I'm just going to flick to the next slide. So the funding, so we were successful with our funding, and we got £148,000 from HEE to trial our proof of concept, which was for the development of a forum within GM for supervision of our advanced clinical practitioners across secondary care, primary care and community services. Included in that is the identification and support of some development opportunities to support our APs to meet all 4 fields of practice. And part of it as well will be about how we evaluate this opportunity working in partnership with the HEIs. So delivery is going to be via some project leads. So we are looking to offer 1 day a week opportunity to 3 ACPs to lead on this project. So that's either 1 day backfill or 1 day just funded if somebody's only part-time at Agenda for Change Band 8A. To support ACPs to lead on this project. We'll work in partnership with the university to scope out the ACPs across the system, and they'll work with the university to do an evaluation of the project. The project really is the development of a multi-professional, multi-system AP forum, the implementation of that and evaluation, and then outline a sustainability model. So what do we need to do once the funding's gone? How do we keep it going? What resource will we need? That's the sort of thing we're going to be looking for. And the opportunity to share the work that they've done with the Northwest ACP faculty. The work or the submission and the work going forward is about collaborating in all partnerships. So we're looking at this as a system approach. So some of this will be linking in with the GM Training Hub. They're already going to be doing, got funding for some scoping around advanced clinical practice in primary care. So we'll need to align the work in relation to that. It'll be about working in partnership with the university leads. It will be about supporting, there'll be support available from the GM Advanced Clinical Practice Group, which is newly being formed. It has been around for quite a while, but we're looking for new membership onto that group. And collaborating, as I said before, with the Northwest ACP faculty. And the others are how this aligns to the GM workforce strategy and people plan and the HE mandate around workforce transformation. Part of the work, so we've identified some key milestones. Part of the work will be with the universities as well. So when expressions of interest is going out to the universities across Greater Manchester for them to do some scoping and complete the evaluation. And there's a variety of things that we want them to scope around ACPs across Greater Manchester, that not just including the number of ACPs that we've got, but what supervision do any ACPs have, if they have any, what development is in place for them, what issues are around for them, what appraisal that they have. So there's a variety of things that we're going to be asking the university to scope. And again, they will work in partnership with the project leads to deliver on this. So I'm not going to go through all the milestones. We're running a little bit late, so we may well not meet some of these milestones as we've put them there, but there is flexibility in the project as long as we deliver and have an output of something by the end of this financial year. Oh. Has somebody's microphone come on by accident? Right, thank you. So the expected outcomes, we're hoping that at the end of the project that we will see some improvement in our advanced clinical practitioners and our trainee advanced practitioners' health and wellbeing. That it will look at how we increase, how retention might be increased within the workforce across the system and create more flexibility within the workforce. The idea of the forums as well is that people will get to meet people from different parts of the system. So secondary care, primary care, the PIVO sector, community services, and then that will enable improved communication across the system and within neighbourhoods. And showing that APs are up to date and offering them some development opportunities. And then raising the profile of the AP role in all settings across the system. Governance will be in place, so as part of the project they'll be reporting into the Retention and Development Workstream, which aligns to the Workforce Oversight Committee for nursing midwifery and AHP workforce supply, and also to the GM Workforce Collaborative Steering Group. And that is my brief presentation. If there are any questions. What we are really looking for are to create that interest for some advanced clinical practitioners in primary care and community settings and in secondary care. So we've created enough backfill so that there's an opportunity for 3 people. And the ideal will be if we had somebody from secondary care, somebody from primary care and somebody from a community background. It can be a nurse, it can be an AHP. Don't mind as long as they're an advanced practitioner. And we will support them through that. There'll be a lot of support to deliver on the project. So we're looking for interested people, and if you know of somebody that would be interested or yourselves would be interested because you're an advanced practitioner, we will be sending an expressions of interest out by the end of this week for people to put themselves forward. We're also looking for some representation on the advanced practice, the GM advanced practice group that is reforming and looking at membership. And this is, again, we'll have oversight of this submission and this project, but we'll also lead on some other initiatives around the advanced clinical practice as well. So that tends to be what we're looking for. Is there anything else you want me to add, Leslie?
No, that's great. Thanks, Carol. Cora's asked a question here. She's asked, where are the details of the forum?
So the forums are going to, there isn't any details of any forums at this moment in time. The project is a proof of concept. So the submission we've put in is to say we've got this idea that it would be great to have either a GM system-wide or a neighbourhood-wide forum, supervision forum and development forum. That's the proof of concept. What we're then going to do, we're going to, the project leads that will be in post will develop these forums, whether that's a system-wide forum or a local place in the neighbourhood forum. We're going to get them to do a little piece of work to see what will work best for the system and for the individuals, really. So they'll do some scoping, they'll work in partnership with the universities. It's a really good opportunity for an ACP to cover some of those pillars that they're not quite fulfilling as they would like to at this moment in time. So there isn't any information on forums, but watch this space, there will be.
It's a fantastic opportunity, Carol, for an advanced practitioner. Yeah. And what we can do is we can send that flyer to everybody that's joined this chat today. So for yourselves or for anybody else you might know that could be interested in that opportunity, we can get that out through this link.
I'll put my email in the chat if anybody wants any more information, if I can I?
That's great. Thanks, Carol. Thank you for that.
Yeah, I'll
Really
put my email in, and then people can just, you know, either email me. Happy to share the bid, but we are hoping to go out and get the ball rolling on all of this in the next in this week, really.
This week,
to get ourselves organised. Make sure I put my name. I can't do two things at once. Must be me. Can't talk and send me email. Has anybody got any other questions? Any other thoughts? Do you feel that this is something that's a gap or a feeling that ACPs have had? There is a gap in that. We've picked something that's going to be useful for the system. Feel free to just put something in or put your thumbs up.
All very quiet, Carol.
I know. Is that a no then? Yes.
Yeah, there you go. Huge gap, very much needed. Thank you. Thank you. Yeah, right. Oh, yeah, definitely. There you go.
See, they all move like I'm dead slow at typing up.
It's Teams today, Carol. It's slow. It's slow. Thanks, ladies. That's great. So we'll get that flyer out to everybody that's registered today as soon as that comes out and everybody's got that opportunity and they can send that far and wide for us. Thank you, Carol. Thanks.
Yeah, if anybody just wants just a quick chat about it, just email me and we can put some time in. That wouldn't be a problem.
That's lovely. Okay. Thanks for that, Carol. Thank you.
Okay.
Thanks. Okay, so let's move swiftly on then. So we would have had the Q&A session there, but I think we're just running quite to time here. We're going to move on to part 2. And I'd like to introduce a number of primary care colleagues who would like to explain the benefits of the Greater Manchester Leadership and Development Programme that we're currently running, which is the CARE programme. This is a nationally designed but locally developed modern leadership and development programme, specially designed for nurses, and it uses a combination of specialist development workshops and modern tools for connectivity in both networks and across communities. We know that nurses are the frontline experts and we've got such great ideas around patient care and population health management, and this programme gives the time and the space and the support to develop those ideas. The programme is currently running Greater Manchester for nurses in general practice, and there are 67 places on the programme, and we're currently booking places for cohort 2 and 3. So I'm pleased to introduce Jonathan Henderson, who is the project manager for the CARE programme in Greater Manchester, Janet Thornley, who's the strategic lead for BMLK and the NAPC CARE programme, Carol Jarvis, who's a practice nurse and a CARE participant on cohort 1, Caroline Lomax, who's also a participant on cohort 1 and a practice nurse, and Maria Murphy and Moira Organzaki, project leads for the GM CARE programme. Thank you. I'll leave it with you, John.
Thanks very much, Leslie. I'm going to be really quick because the more interesting people are to come. The people who've been on the course are the examples of other regions or other areas that have done the course. What I wanted to do is just introduce myself again, give you a simple number update, and just give you some information around cohort 2 and 3. And then I'm going to pass you on to Janet, who's from BMLK. Starting off on the flyer, I just wanted to say everyone should have seen this flyer. This is the original flyer that we created from the programme, and it seems to have developed into the flyer, hopefully, and we'll learn about that today off Janet and other experiences. And I just wanted to kind of bring up the flyer and the interest of the General Kitchener, and hopefully you've been seeing our comms go out, and all our comms are our Twitter feeds, and we've tried to use as many of the same pictures as we possibly could just to keep the continuity of the CARE programme. So going on, can I have the next slide, please, Claire? Yeah, so we need you to support the programme, and you have. So we, as expressions of interest applications go, we've had 7 out of 10 localities. So we're still awaiting some interest from Oldham, Trafford, Bury. So obviously, as I go into it, we need support from these localities. I'm not sure who's on the call and if anyone's from these localities, just make sure you're getting the comms. For the first cohort, which started in March, we had 11 nurses that are currently on the course. Obviously, we're going to hear from one of the nurses today. Cohort 2, we're currently going to have about 12 places, which is predicted at the moment. Cohort 2 starts on the 1st of June, and I will go into the date shortly. And like Leslie says, we do want to really, this is our final push. This is our final offer. We want GPN nurses. We've aimed for GPN nurses. So we are really pushing for that GPN nurse intake. I think we've got an expressions of interest out till the 7th of May. And then if we cannot complete the cohorts, then we will be pushing it out to other nurses within the system. But we're not going there yet. We do want to encourage GPN nurses to get on this course. It's a fantastic opportunity. It really is. And I'm hoping that we'll hear more about that when people who have been on the course tell us about it. The comms that we've sent out, so I'm hoping that you've all seen comms that we've sent out. So we've sent out to all GP practices with wider team, i.e. practice nurses, with GM workforce leads, CCG nurse leads, GPN collaborative. We've been to the forum, obviously today and the last forum. Attendees at any meetings that we're going to, GP boards. So we always get the GP excellence team, anybody who's working within the project to push any meetings that we're going to, and the PCM business managers. So we have sent comms far and wide. We realise that it's been a bit of this last 12 months is a difficult period for everybody. And I think that yourselves, as well as us, will realise that it's quite difficult when COVID's not really left us yet, but I think business as usual is very required at the moment, and we're starting to go into clinics, waiting lists. So we realise that it is a really busy time for all the nurses, GP practices, but there is a mass benefit to having leaders within the system to tackle these times. So it's the chicken and egg situation that we're in at the moment. So all I wanted to do is just say that we really need you to share this far and wide for our final offer for our nursing colleagues. And if you are, or you have a colleague or anybody who's interested, please get them to apply to us for this last ditch effort. Can I have the next slide, please, Claire? So what are our cohort dates? Right, our cohort 2 now starts on the 1st of June and finishes on the 14th of July. And then cohort 3, which is our final cohort for this programme at this moment in time, starts on the 23rd of June and it finishes on the 11th of August. So if you can imagine, I think time for us all is going really quick. Weeks are going by, weeks are flying. So if we have any interest, I know the 1st of June seems like it's a bit away, but it really isn't. And the 23rd of June is really not far away. So from me, as an encouragement, I just encourage the group, please, if you have an interest in it, if you have any questions, please contact Leslie, the team, me. All these slides will go out to yourselves. You've got all the links onto the website, to Leslie, to the GP Excellence, where you can put your expressions of interest in. And we really are pushing to get GPN nurses because you deserve it. And you've worked really hard this year, and with all the vaccination processing and being involved in the digital passport and the amount of names that we've had coming through the system, nurses wise, it really is a tap on the back for you, and it's a fantastic course. And like I say, I'm not going to talk anymore. I want really this care program session to be about experience, and the speakers that will come on will give you the experience and give you the realism of it. So without further ado, I'll pass you on to Janet. Okay.
Yeah. Great. Hi everyone, really nice to be here with you. I've got a few slides, but actually because I know that we're a bit pushed for time now, I'm not going to share all of them with you. Can you see that? Yeah.
Yes, thanks, Janet.
Right, okay. So my name is Janet Thornley and I'm a strategic practice nurse lead in Bedford, Luton and Milton Keynes CCG. But I also have a couple of other hats. I'm a deputy clinical director for my PCN. And the reason the care programme came around, I'll just give you a very tiny bit of background so you know where the roots are, and they are with you. Is that as a deputy clinical director, we weren't really getting any projects off the ground. And when I spoke to nurses and my colleagues, nobody really knew
what a PCN was, or where their place was, or what they could do about things. So I thought, actually, this isn't working. I'm getting something really wrong. I'm not doing my job right. And with my strategic hat up, working with the training hub, actually I set up a pilot scheme so that for each of our PCNs, we had a lead practice nurse, so that they could help, and they could be that link between the training hub, the workforce and the clinical director. And then once they were in post, I was thinking, what kind of things would I want to know if I was a nurse, maybe setting up a few projects, or I've got loads of ideas, I just don't know how to go about them. So I started to design a programme that I wanted for my nurses. And I had a couple of colleagues from the NAPC, and they joined me, my colleague Claire, who we do a lot of delivery with. So actually we came up with the care programme. We didn't call it that to begin with. It's now gone national, and we're now really, really excited to be working with you in Greater Manchester. The idea is there are 10 sessions altogether, a couple of hours, like Johnny has said. The first one and the last one are a launch and a celebration. The second 4, so session 2 through to 5, is all about practical stuff, how we can help you. So I'm just going to move on to, I'm not going to go through all of them, but Leslie can have these slides. So actually there are 4 about what is population health management. We do a bit of myth busting, make it really easy and understandable. A bit of QI, so a couple of tools that might help you when you're trying to get a good idea off the ground. We do a session on teams and influencing people around you, how we can have those really effective conversations, stuff that I've never had taught to me at all, but I find really useful. And then we have 4 sessions that are brilliant with someone called Rebecca Howard of Shiny Mind, and she's a leadership psychotherapist, and she does everything about you. And it's self-awareness. How do I see the world? How do I want the world to see me? Taking ownership. We know you have a voice, but do we feel that we can amplify that, or do we need to find that confidence within us? We've been working for years in a really hierarchical system, but actually I've got tons of good ideas. I just need the confidence to get out and do them. And we hope that although you probably have been on leadership courses before, we think there's something different about the care programme because it's a practical application. We do usually ask you to think about a good idea. So I don't want you to run for the hills with the idea of a project. There's no test involved in this programme, no exam, no assignment. We ask you to think about an idea or a project that you may want to get up off the ground, and we're there to help and support you. You don't have to have that project finished by the time the programme finishes. You may not even have got out of the starting blocks. That doesn't matter. This is all about you finding your confidence, talking to other people, maybe other systems, maybe nurses in another practice, in your PCN, things that we don't generally do. Building on the relationships, I'm sure, like me, you've all made in the vaccination clinics, just to share those ideas. And actually, we're getting some really, really good feedback. So this is some feedback from a session from the programme that we did in Nottinghamshire. So 100% of the participants felt more able to talk about population health management. They felt more able to put their ideas into the practice. Actually, it helps with emotional well-being because those sessions about you with the psychotherapy is brilliant. Everyone comes away feeling shiny and excited and a bit more motivated. Joy comes back to work at a time when it's been flagging. Really, everyone's been under the cosh. And everyone is saying that their influencing skills and leadership skills have improved because of the sessions they've had. And these are just some of the evaluation that we've got. So everything has improved. This one about clinical skills, we put that in as a ringer because actually we don't teach any clinical skills at all. It's not a clinical programme. But what they're saying is that because they feel more confident generally and they have more time to think about things generally in patient care, they feel that their clinical skills are improving because they've had more time to think about them. So actually everything about their aspect of work seems to be improving because of the care programme. And these are some of the comments, and I don't want to labour the point, but it's just that this is a really new type of programme. It was designed for nurses, by nurses, me and a colleague, and we've had lots of input from NHS England and NAPC. The nurses that have been coming on it are really enjoying it, and I'm going to stop very shortly to let your colleagues tell you how they have found it. But there's no pressure. Nothing that you have to complete. This is just coming and having some conversations and maybe learning a few new skills to put those ideas that you've been having over years as patients walk out and think, what if I did that? This is a bit of an idea of some of the projects. You might have your own idea. We have someone that's doing diet for 4 lorry drivers. You don't have to have a big group of people. So she's wanting to help lorry drivers make better health choices when they're in that roadside cafe. So her project is on 4. Another one is sending texts out to 5 diabetic patients as well. But we have staff wellbeing projects up on the go, asthma, diabetes, whatever your interest is. We can support you along the way to do something different that you've always been wanting to do at work. I'll put my email in the chat. This is Claire, who's the lead, who does more of the admin for me. But it is, I think, a really good, enjoyable project, and one that I hope you will really enjoy joining us on. And we would love to see you and can't wait to work with you. We're already having a great time with Johnny and Leslie and the community that they've brought together. So I'm going to step aside now and let someone else tell you about their actual experience of the care programme. But do please get in touch if you would like to know more about it. But I do hope you'll join us.
Thanks, Janet. Thank you. That's great. Can we move on to Carol?
Yeah, hello. Hello, everyone. So I've been part of the first cohort for the Care Excellence programme. So the programme, which Leslie and Janet have already said, which is to work within your PCN to improve your population's health. And it's about developing necessary leadership capacity to drive and sustain local transformation, putting us nurses in the lead around system change. So next slide, please. Okay, so us nurses are often at the forefront of change, and sometimes in primary care we're not given the opportunity all the time, all the resources to make those changes. And I'm sure there's lots of new nurses out there who look at how things are done and who want to make changes but don't know how or can't get your ideas heard. This programme will give you the skills, time and support to do so and put them into practice. It will help identify gaps in care and at new ways of improving care. The programme will allow you to put all those innovative ideas which you feel will benefit your patients into practice. The course puts you in contact with lots of other professionals to help make those changes. And we all know that sometimes in primary care it can be a bit lonely, and this really allows you to network with other nurses and you can all share your ideas. It's a very warm and very safe environment where everyone is encouraged to listen and express their ideas, and everyone's contribution counts. You get an abundance of support from those within the group, and you're never on your own. The common aim is that we have a passion to provide the best care to our patients and make that care available to everybody. And that can be using apps, social media, or any new technologies that are out there. Next slide, please. So my project is a community garden project, and it fits into the NHS 5 steps to a healthy mind. That's to give, connect, take notice, learn and be active. Next slide, please. So I found that during COVID it's left many people, young and old, lonely and isolated. So what I'm trying to do is to bring all of the ages of the community together. But not only that, it's helped people at work feel motivated, and it's just to improve everybody's quality of life, everybody's quality of their mental health. Okay, next slide, please. So the actual aim of the project is to try and reduce GP appointments by improving mental and physical health. Gardening, according to the RHS, so the Royal Horticultural Society, they've done a study and it says gardening reduces stress by 4.2% and improves well-being by 6.6%. So what I'm doing, I'm using local community aid with the project from keen gardeners within the community, the patient participation group involving the local sheltered accommodation, which is next door to the practice, and the local garden centre, which does a lot for people with learning difficulties. So just to give you some ideas. But the keynote that we've learned from the project is to start small and expand as you learn what works and what doesn't work. And even if you've helped one patient, so one patient to start with, then you can say it's been a success. Thank you.
Thanks, Carol. That's fantastic. Shall we move on to Caroline?
Hiya. So I'm Caroline. I work at Castleton Health Centre. You can go to my next slide, please. It probably makes it a little bit clearer. So basically my background is I'm a general practice nurse and I've been at this practice now for about 21 years. And like most nurses, come to work, do the same clinics day in, day out, absolutely love it. But there's always just been that one thing missing. Love chronic disease management, health promotion, but quite often we're led by guidelines and it does sometimes feel like you're just ticking boxes, and I had been feeling like I'd hit the ceiling of my professional development, so looking for which area I could develop in. So super excited learning about the care programme, albeit the word leadership did scare me to death, and I did think imposter syndrome kicked in, and it's like, can I really do it? Am I good enough? But actually those doubts just get quashed on the first session, because as Carol said, it is so relaxed. It's so relaxed. All the facilitators are absolutely amazing. It's a really comfortable area where people can just share opinions, ideas, and get loads of support, and not be worried that your idea is not going to work, it's not going to take off. If it doesn't take off, try something else, but you've got that support. And yeah, I can now comfortably say and acknowledge that as general practice nurses, we are all leaders. We see patients on a daily basis. We help them make decisions in their life. So I am a lot more comfortable with that, and in what, only 4 weeks. Next slide, please. So what the care programme has given me so far. So yes, it's given me the courage to try and make a difference, to take those risks that perhaps I wouldn't have done on my own if it wasn't as part of this programme. Luckily, the project that I wanted to implement is actually taking off, which I will talk about a little bit in a minute. So I didn't have to change my direction. But I do feel, like I said, after only 4 weeks, we've been given a voice. So there's 11 of us currently on the programme, and it's just amazing, the safe area that you're in. It does make you feel really respected, empowered and valued, and encouragement. I've never known encouragement like it, honestly, and I would say to any general practice nurses out there that are considering it, just do it. Honestly, just do it. You will be connected to so many inspiring nurses countrywide, like I have. And Twitter, we've all been encouraged to go on Twitter. So for the first time ever, decided to have a go, and already managed to connect with about 150 nurses countrywide. So it's opened my eyes massively. And I just feel it's now giving me the tools that I need to build a positive team around me that can help me implement the project that I'm going to do. Next slide, please. So a little bit about my project then. So my project is attempting to engage young male adults between 18 and 24 into primary care in order for them to take ownership of their own health and well-being. Now, what I've noticed over the past 12 months, especially due to COVID, is that there is a lot of social isolation within this age group. So whether they're doing college, university, work, it's all from home within one room of the house. They're not meeting friends, they're not socialising. And we've seen quite a lot of mental health deterioration because of that. The NHS plan, when I looked at it, did seem to have this massive gap that jumps from the young and early years, then it jumps to long-term conditions and aging well. So I did feel it was a massive gap that I needed to get involved in. And I just feel really passionate that, you know, early intervention is key. The sooner we can get in there, the sooner we can engage these young men into general practice and kind of just make them know what we offer. It will have better outcomes. And just a couple of data headlines that I've not put references up, but for example, patients with anxiety, we know have double the amount of GP appointments compared to practice average. So if we can get in early and ask the depression screening questions and ask about anxiety and support them, not only are we going to reduce illness, we're also going to reduce the demand on GP appointments, just the same as patients who are obese have over double the amount of GP appointments compared to those in normal age range, normal range. So again, if we can address these matters early, we've got a better chance of making a real difference. Now, I do appreciate that this is a really hard to reach age group, so I'm kind of tackling it from all angles at the moment. Next slide, please. Yeah, so the ways that I'm tackling it at the minute is by I've done a search looking at the amount of patients I've actually got in this practice around that age group, which is about 357. Narrowed it down. I'm now at the point where I'm sending text messages and getting responses back or not, as the case may be. I think I've had about 20% of positive responses back so far. But intending to take it out on Instagram, on Twitter, Facebook, social media, because I think that is the way we're going to engage these lads. I've pitched this to the partners at work, and I'm so lucky that, you know, I've had so much positive support. So the team of helpers that I've got at the minute is a massive skill mix, but everybody is bringing something different. So from GP partners, I'm lucky to have the clinical director on board, practice manager, admin, reception, social prescriber, and everyone has got different ideas that they can help with, and you know how we're going to bring all this together. So it's really exciting, and I'm currently at the point of now developing a template similar to chronic disease management that will tackle all the basics like your blood pressures, height, weight, BMI, look at all the RIMS and VACs, if they're up to date with them, if they're going off to uni, sexual health, travel health, testicular self-examination, depression screenings, young carers. So the list is endless, and also trying to set up a Saturday morning young men's health drop-in clinic as well, so we'll just see how that goes. Next slide, please. Yes, as I said, my plan is now to gather information and statistics, which I've actually done. I've sent the first text, and I'm now devising the template. Appointments are now going out to actually do these health checks, and then in the interim, ideally I'm going to be sending little nudges out, little text messages to these lads, supporting them, whether it's be with weight, mental health, whatever it is, just that little nudge of support, because we know it's going to make a difference. And then I will be auditing it after 6 months. So next slide, please. Yeah, so if you want to anyone has any questions, any nurses out there just thinking that it might be for them, or you're a little bit hesitant, please get in touch or follow my journey on Twitter. I'm trying. I can't guarantee it's I'm doing all the right things, but we're just having a go, and that is what it's all about. Thank you.
Hi, thank you so much for that. It's Maria Murphy, and I've been involved in the steering group here, and I've heard how good this programme is, but it's blown me away with Caroline and Carol with those projects and your enthusiasm and how keen you are, and just looking at the comments that's in the chat, it's just amazing. So it's fab. It just sounds so good. So really, I'm just basically here to say that we just want to really encourage anybody who is considering this to really put yourselves forward. We need nurse leaders in general practice. You're all leaders already. You've got the skills, so it's just building on the skills that you've already got. And this programme, as you've heard from the two that have just started it, they're really building those skills. So please, if you're thinking about it, the link, there is another slide, I think, if you can move it on, which has the link. There we go. So it's got the information there. The website has been put in the chat as well, but you've got in there information about the cohort dates again. It's got the expression of interest form and where you send it to. To reiterate that we were looking for a nurse per PCN originally. That limit's now gone. So any nurse who is interested, we really do want to hear from you. I know that Leslie would be really keen if there's anybody who wants to talk it through first of all before putting an expression of interest in, that she would be delighted to have that conversation. And it's just, yeah, it's a fantastic opportunity for you, for your practice, for your PCN. If you can't fill in the form completely, just send us something in and we'll come back to you and really support you through the process. So it's just really if there's time for questions, if anybody has got any questions.
Hi Maria, it's just Moira. Just to say, it is a fully funded course, so you get paid for your 2 hours on the webinars and then 2 hours support after. So I know there's been something in the chat that it wasn't funded, but it is fully funded, and the practices get funding to allow you to come on the course. And it's open to anybody, newly qualified nurses, nurses that are due to retire. Don't think you're too old like me and Gray. I promise you're not. Experienced nurses, anybody. We just want the nurses to get a voice. So do come along, or any questions you can, as Maria said, email, and me and Leslie are quite happy to chat about things. Sorry, Leslie, over to you.
No, that's great. Thank you. Thank you for everybody for that. It was so passionate. Really good presentations there. And thank you, Janet, for coming under these extreme IT circumstances as well. Some really great comments there, and I think we'll have more nurses joining us. There was one question in there about care home nurses. Please, if you know care home nurses that are interested, ask them to put an expression of interest in. It's open to nursing. We want nurses on the programme. If we can't fill it with our practice nurses across GM, then we want our community nurses and our care home nurse managers to benefit from this programme. And we've all got great ideas about improving patient care and population health. So we all want to release that inner leader, I'm sure, and make change happen. So I say, get signing up today. Contact me, Moira, Maria, Janet, anybody that spoke today, and we'll give you more information. So thank you, everybody. That's been great. So I'm going to move swiftly on then, because we are a little bit behind for Sarah's part here. So hi, Sarah. Sarah's from the screening and immunisation team, and she's going to highlight and share some outstanding examples of practice during the COVID vaccination programme. Thanks, Sarah.
Thank you. Let me just share my slides. Okay. Can you see that?
Yes, thanks, Sarah.
Yes, fab, thank you. Okay, so my name's Sarah Jones. I'm from the Screening and Immunisation team, Greater Manchester. So I've just come to talk to you about some of the work that's going on across Greater Manchester relating to inequalities in the COVID-19 vaccination service. So I'm just going to highlight some of the really good practice that's going on across GM in all areas. And I know a lot of you will be involved in the programme and will be involved in some of these things. So if you are, please, could you share stuff in the chat if there's any specific things that you're doing or any groups that you're working with, just so we can share some of that good practice, because I think that's really important. And I think if you're not involved in the COVID vaccine programme, a lot of the initiatives that are happening across GM for this programme could be replicated into other programmes such as flu and other immunisation programmes, and also the cancer screening programmes. So if there's anything that you think you could replicate, then that would be really good too. So first of all, just to highlight what the vaccination programme is in GM. So this is of last week. We've just done just over 2 million doses, which is amazing, really. So 1.6 million first doses and 500,000 second doses. And across GM, we've got 78 vaccination sites, different models. So we've got the MassVac site at the Etihad, then we've got hospital hubs, and then local vaccination centres, which are a mixture of primary care networks and some pharmacies as well. That's going to be changing a bit in the next few weeks, but there will be services in every area. And then we've got the uptake across Greater Manchester, so 95% nearly for the over 80s, which is just brilliant. And then obviously as we go lower through the cohorts, the uptake does drop slightly, but it's still quite high. But within those unvaccinated people, there are quite big inequalities in the people who aren't getting vaccinated. So that's just what I'm going to cover today. So the North West have produced what they've called a menu of reasonable adjustments, which is a brilliant document with examples of good practice and ideas for working with all of these groups. So it's about 70 pages long, it's really big. But if there's a group that you are working with or you would like more information on, then it's a great document to use, and I'll make sure it's shared later. And in Greater Manchester, we've also produced a framework for inequalities, which is available on our website, which I'll share the link to in the chat. And thank you to everyone who's been working on this programme, because there's been so much work to reduce some of the inequalities. I'm not going to talk about all these areas because I'd be here all day, but I've just picked a few key ones. So this is a survey that was done in January, so right at the beginning of the vaccine rollout, and this is in Greater Manchester, and the likelihood of people taking the vaccine. So I think this will have gone up quite a bit now. I think people are a lot more confident in the safety of the vaccine. However, when you look at the people who were least likely to say they would take the vaccine, it's people from ethnic minority backgrounds, people who don't speak English as a first language, Muslims, people who live in deprived areas. So there's definitely a gap in between who would be confident in taking the vaccine and those who aren't so much. So in terms of ethnicity, we know that there's people from BME backgrounds have been adversely impacted by the COVID-19 infection, and those reasons are wide-ranging, and they could be due to underlying health conditions, deprivation, occupation, household size, access to healthcare. And we know that uptake within the flu vaccine programme is lower within Black, African and Caribbean groups. And vaccine hesitancy research shows that there's more hesitancy amongst these groups. However, we also know that data is poor on ethnicity. It's not always coded on GP systems, so it can be hard to measure. From the data that we've got at the moment on vaccine uptake, there's a lot of lines on this, so don't worry too much if you can't see them. But the line at the top, which is the highest uptake group, is white British. And then you can see quite a big gap between the highest uptake and the lowest uptake. So down here, we've got Black, British, African and Caribbean. So there's a good maybe even 20-30% gap in between those who are white British taking the vaccine and those from other ethnicities. Deprivation has a big impact on people's risk of COVID-19, and you can see here that the deaths from COVID-19, this is from just the first wave, not the most recent wave we've had, but it's much higher in those areas that are ranked lower with more deprived areas than those more affluent areas. And again, we can see that in the gap with the vaccine uptake. So the two lines at the top, the most affluent areas, and then this one is the most deprived area. So again, at least 10% difference in uptake within these areas. And that's not just related to ethnicity. So we know that people from white British backgrounds in the most deprived areas are also less likely to have had the vaccine. Disability is another key area. People with learning disabilities are 1.4 times higher than the general population to have died from COVID-19 in the first wave. That's reflected with amongst people with a physical disability as well. And at the moment, for people on the LD register, the COVID vaccine uptake is about 10% lower than the general population. But that's only the people who are on the register. That we know that that's an underestimation as well. So it's hard for us to know if we're meeting the needs of all these groups. So what are the barriers that we're trying to work with? So there's a wide range of barriers to access for the COVID vaccine. It could be things about accessibility, inconvenience, travel times to clinics, people not wanting to take public transport at the moment. Then things such as cultural beliefs, their understanding of risk, and whether COVID's a risk to them or not. People who aren't registered at a GP, language barriers, the opinions of people's peers and the people around them of whether they take the vaccine or not, and sometimes a lack of endorsement from people from their community. So these are some of the things that we're trying to combat and break down the barriers to. So the work that's been done across GM, so I'm just going to focus on a few key groups. Patients on the LG register, there's been a brilliant amount of partnership working to ensure that this group are offered vaccination. So PCNs have been working really, really closely with the specialist LD teams in the local trusts to make sure that everyone's been offered the vaccine and that that any reasonable adjustments have been met. So offering quiet clinics for people who might struggle in busy environments or who might need a longer appointment and a bit more time to get used to it. How-to guides to support vaccination centres, additional support and access and appointments, referrals for people who can't be vaccinated within the PCN to be maybe vaccinated in a different venue or possibly having a home visit. There's loads of easy read materials available, and we recently held a webinar featuring teams from Wigan and Salford who shared some of the work that they've done. So that's been recorded around how they offered their appointments and also how they tackled things like best interest decisions. And that webinar is available online. If anybody wants to watch it, I'll share the link of how you can access that. Patients with physical disabilities, there's been a lot of close working with third sector organisations, such as the Greater Manchester Disabled People's Panel, ensuring that clinics are accessible, things like just basic things that some people would struggle to queue for long periods of time, so there's the seating available. There's been walkthroughs of clinics to kind of highlight areas of improvement and kind of peer evaluate how accessible the clinics are. Some areas have been offering accessible taxis to those who need help getting to the appointments, pop-up clinics for groups such as those with hearing difficulties. And there is e-learning available to support patients with hearing disabilities, difficulties, which I'll share in the chat as well. Lots of areas have been using their community champions to improve uptake in the programme, and they have been using them in some areas throughout the pandemic to help with things around the COVID infection as well, social distancing, welfare checks. So there's a lot of door knocking happening in communities where they're having conversations about their well-being, about the infection and the vaccine, and promoting pop-up clinics. And these conversations have been really successful and have really helped increase people's confidence in accessing the vaccine. And this is a slide from Tameside and Glossop sharing some of the work that they've been doing with their community champions. So ethnicity, lots of work has been done around pop-up clinics in mosques and other places of worship. There's been a lot of engagement with faith leaders encouraging the community to access the vaccine. So here we've got an example from Oldham, where they've been working with faith leaders and asking them to record videos explaining that they've had the vaccine and that they support it. This is an example from Bolton as well. Using volunteers, speaking community languages, and running clinics in conjunction with the faith groups or other charities or local organisations, having those trusted voices of people within the community that will promote the vaccine. And this is just a slide with some other examples. This is from the one of the toolkits that I mentioned earlier, just about some of the engagement work that's happened, for example, with MFT to promote the vaccine amongst BME colleagues at Tameside around the work that they've been doing, translating videos. So the Caribbean and African Health Network have been doing a lot of work as well to promote the vaccine and holding webinars to try and dispel some of those myths, which have been really successful. And we also helped organise a joint clinic with MHCC and the Caribbean African Health Network, which they promoted to the people who've been attending their webinars, and that was held in Moss Side. That was really successful. Vaccine buses have been used so far in a couple of areas, and again have been really useful. And these have been used for lots of different communities. So homeless, mosques, focus on areas where there might not be a vaccine clinic and people might need a bit more support in accessing it. There's been different models. So some will use an appointment model, some are doing drop-ins so people can just turn up for it. Some are doing a bit of a mixture of both. So we're hoping to roll this out and expand it further across Greater Manchester. So the last group I'm just going to touch on is homeless. So there's been a lot of work offering the vaccine to homeless and rough sleepers, with many areas offering bespoke clinics or using the vans and buses to deliver the vaccine to homeless, rough sleepers and people in temporary accommodation. And again, they've been doing a lot of holistic work, carrying out health promotion and health checks. And these are some quotes from Urban Village in Manchester for how important the service has been to this group, and that they might not have access to vaccine if it weren't for this. And this work's also been replicated with other groups, such as asylum seekers, refugees, Gypsy, Roma and traveller communities, and sex workers. So there's a lot of work going on. And one of the key things is helping people to register with the GP, because then going forward, they can access further support. So we've got lots more challenges and work to do. There's still quite a big gap in between some groups, and we could we need better data as well to understand some of the areas. And as we work down the age groups, obviously for the under 30s who aren't being offered AstraZeneca at the moment, that's the only vaccine that we can use for pop-up clinics. So if we need to focus on pop-up clinics for that community, we might need to look at different ways of targeting them. So thinking about going forward, how can we replicate some of this really good partnership working for other programmes? You might have already done work with around groups such as patients on the LD register for flu vaccination. How can we replicate that with things like cervical screening and other immunisation programmes? And this is just a link to the resources, so I'll put this in the chat as well. We're holding weekly workshops on inequalities. They're just half-an-hour sessions on Thursday lunchtime, focusing on a different group each week. This week's on deprivation, so if it's something you would like to attend, then please let me know, and I will I'll send you the calendar invite. Okay, that's it from me. Thank you.
Are
you on mute, Leslie?
I'm on mute, yeah. I'm saying that was superb. Thanks very much, Sarah. What work's going on out there? Has anybody got any questions for Sarah? Well, we've got a few minutes left. Sarah, if you put your email in the chat, I'm sure there will be questions coming to you from that. But I'd like to just highlight something there. I think as nurses, we're quite aware of some of those barriers. As practice nurses, we know what those barriers are for our communities. However, we don't always see that data behind it. So that data was extraordinary. I don't know whether I'm the only one that's probably not seen all that. I'm sure nurses out there don't see that quite often. So thank you for providing us with that today. That's been really good. And those fantastic examples.
Yeah. Data's been really a hard thing for a lot of our programmes. It's never been broken down by ethnicity and things like that before, and it's something that's getting better, but definitely yeah, in the past we've not had that really.
Yeah, COVID's changed a lot of things, hasn't it? So fantastic.
It has, yes.
Thanks for that, Sarah, and I know you'll be back next time with more for us, so that's really good. Thank you. Thanks very much. So with a few minutes to spare, I'd like to say thank you to everybody for today, and apologies again for the Teams issue. Apparently it was a worldwide issue and not just a GM issue, which is great to know. So if you want to sign up for anything for healthcare support workers or know more information, contact Dawn O'Brien or the Training Hub. If you're interested in the CARE programme, then myself or anybody else that has been speaking about the CARE programme today. And can I just leave with saying, if you've got any comments or any ideas for our next forum, please put in the chat what you feel. Thank you. Thanks very much for attending today. And we're right on time.
Thank you, Leslie.